Hi, Darryl. Great to have you here with us.
Thanks so much. Great to be here.
So, I'm excited as we're here to talk all about risk-bearing IDNs, or as some may call them, payvidors, which are at the same time one of the most influential yet least understood forces in healthcare innovation. Before we dig into that, let's start with a bit of your own background. You've had a unusual journey, starting as a physician and now serving as COO of one of the largest health systems in the country. Can you walk us through that arc?
Sure. I started my career as a cardiologist, and if you'd have asked me 20 years ago what I'd be doing now, I would have said I'd be practicing cardiology, caring for patients. As it turns out, over the course of time, I was at a health system in the Midwest, and this is now dating back many years, found many, many challenges, as we often do in US healthcare. And at one point decided, you know what, I'm going to try to help do something about that. And so ultimately took on different roles. And the last role I had before joining Providence was the chief operating officer of Corewell Health, which is the largest health system in the state of Michigan, also a very large payvider with a large health plan. So I've had many years of experience with care delivery associated with health insurance. I now am the chief operating officer here at Providence, and as you mentioned, we are a 31 billion, seven-state health plan and provider. Our health plan has about 500,000 members, and we have about 51 hospitals with about 125,000 caregivers employed by us.
And for those kind of less familiar with the spectrum within IDNs, I mean, on the one hand, you have the Kaisers of the world. On the other, there's groups such as Providence and Corewell. I mean, what's a good framework to distinguish between them in terms of how they're actually structurally set up to take on risk or deliver care?
Sure. Well, Kaiser is kind of a unicorn in the sense that it is far and away the largest health plan that is also a provider. And Kaiser, if you would look at it, most people would argue, probably including Kaiser leadership, it is a health plan that also is a provider. Immediately when you get from Kaiser to anyone else, and the second largest in the country is UPMC, University of Pittsburgh, followed by Corewell, actually. As you start coming down, we're providers that own health plans because our provider network and provider revenues are far larger than the health plan side of things. With that said, and what really attracts me to being a payvider is when you have a plan and you have a provider, even if it's not your entire book of business, it allows you to experiment, try different things, and try to take risk on the provider side a bit more, where before you might have been a bit averse to that.
Yeah, and I think it's a good lead into kind of the bigger picture of the business case behind being a payvider. And Providence is very interesting in that, as you mentioned, it still earns most of its revenues from health delivery, but also clearly leaning in a very significant way to the integrated payvider model, including operating this health plan in some markets and engaging in value-based payment models across others. So if we were to zoom in, it's a smaller part of the P&L, but why is this kind of combining of provider operations with financial risk so important, even for a scaled network such as Providence?
Oh, sure. I can make a pretty easy statement on this. So, as a provider, and if you were solely a provider in the United States in healthcare, you would look at risk and you would ask yourself, do I have the capabilities of taking on risk? And what is the downside? You see a lot of contracts out there that call themselves risk, but they're really just upside payments. If you really want to take up and down risk, there is risk to that. And it takes a lot of muscle, a lot of effort, and time to get good at that. And many, many providers just say, hey, I just can't do that, or I'm worried about that, or you have a down year where you just didn't expect certain things, and that drives you out of the business. If you have both sides of the ledger, if you're both a plan and a provider, even in a market, you can take on risk as the provider or start taking on risk, knowing that if worse comes to worse and you lose financially, the plan gains, in which case it ends up being right pocket, left pocket, and it works out for everybody while you're learning and trying to get better.
So it sounds like a great hedge, and
You said it.
that's great.
Yes.
Now, to remind our audience, stepping back, this interview is part of our IDNs as Buyers series and should be ideally viewed alongside the downloadable field manual, which you can get at lionbird.com/IDN. And the manual really helps founders navigate these complex organizations by asking the right questions to not just understand what an IDN is doing, but why it behaves the way it does. And I'll kind of allude to that throughout the interview. And so now, as we move toward the how of building toward integration, as you had mentioned, Providence has a payer arm, and that's seemingly through two primary mechanisms. There's the Providence Health Plan with over 500,000 members, as you mentioned, and the Providence ACO, which spans multiple states. And to my knowledge, it's one of the most successful advanced ACOs participating in the enhanced MSSP track, which is, for those who know, a higher risk tier shared savings model. That said, even though the ACO is kind of top of its class, its financial footprint within the organization is still much smaller than the health plans. And so, why continue to invest in both models? What does each unlock that the other can't?
Yeah, I think that's a great question. I'd say a couple things. First of all, I think investing in these things makes us better. And what we learn in one, we can apply to another. And so you brought up two arms. There's actually a third that I often think of. The state of California has multiple interesting risk-bearing mechanisms for providers. And we essentially have, well, many, probably 750,000 almost patients in the state of California that we essentially assume full risk for outside of these programs. So these things taught us to be better. When it comes to MSSP, you mentioned with the ACO, there's a beauty of that. Number one, when you have a provider and a payer, very often you have concentrated markets in some way. And if you look at us, we're in 7 states, as I mentioned. The state that we have the largest population of Providence Health Plan patients, or members, I should say, is Oregon, and we have a lot of concentration there. But if you go to Alaska or Texas or Montana, other places where we operate, we don't have the health plan, but we have MSSP because everyone has Medicare. And MSSP, which is the large program that our ACO participates in, has been really excellent for us. We've really worked hard to make it better. I appreciate what you said about us being really good. We're actually the best. I can say that from last year. We're waiting on this year's data, but we had over 120 million of shared savings brought back to us last year and perform incredibly well. And it's amazing physicians and a network where we really try to educate everyone on the best things to do.
Sure. To expand the footprint of Providence Health Plan across that entire footprint of 7 states, I suppose would be very capital intensive and time consuming. So it makes total sense that, the ACO would allow you to start doing so and gaining those lessons and starting to drive that impact. So it makes a
Absolutely. And I should make one other comment, and you brought it up earlier. In the US, I think we all know now, over the last probably 2 years or so, payers have really struggled. You can just watch the news and look at United these days. It's been really hard.
yeah.
The beauty of the MSSP is it's somewhat independent of those challenges. And so we have done incredibly well on one side, whereas our payer, like everyone else, has struggled over the last year or so.
Sure. So additional hedges within. And so shifting gears, in the manual we talk about buyer mapping, especially when the team that owns a problem within an organization is not the one holding the budget or driving implementation. And a classic case is when you need joint buy-in for whatever solution you're offering from both the plan and provider arms. Yet even in integrated systems, this can be messy as those sides are governed separately and sometimes have regulatory or even legal firewalls between them. Within those constraints, where do you actually see enterprise-wide projects that move the needle and still have potential? And for startups that are watching this, what should they be aware of in terms of where those boundaries might slow them down, and on the other hand, where they could still find meaningful openings?
Yeah, that's a great question and probably a complicated one. I can say that first of all, and I'll think here, PHP, Providence Health Plan, as I mentioned, is a relatively small segment of the overall business of Providence. Where I was at Corewell, It was a larger segment, but still not the majority. And so one fundamental challenge when someone's coming in trying to find solutions for both is that if you have solutions for both, unless they're incredibly meaningful, they end up being just a small slice of the business. And if those solutions don't scale to other payers and allow you to try something different from the provider side, it becomes oftentimes the juice isn't worth the squeeze, if that makes sense. So
Sure.
that would be one. From a, there absolutely are legal and regulatory barriers between oftentimes having to do with our contracts with other payers, the payers contract with other providers. Those things are off limits, but it's easy to navigate around those. I would say at the end of the day, if there is a solution that someone thinks could come to a payer or come to a provider, but work with both, the beauty of working with payvidors is if you can establish relationships on both sides and bring everyone together, there's oftentimes magic made.
Mm.
And so the key, and I would argue would be, is don't just target one side of the ledger, target both if you have a solution, talk about it, but have the recognition that if the provider can scale it to other payers down the road, like I mentioned, that's a huge win for everybody.
So sometimes I suppose you can start in what's called a closed loop model where maybe you're able to kind of get started a little bit faster and then with an eye towards commercializing that and offering it to further plans in order to actually move the ledger as you called it or rise above the relative context of priorities when the overlap is not as substantial as some might think.
Exactly.
Yeah,
And barring Kaiser, you're not going to find that much overlap in most plans.
sure, sure. I think that's an important point. And it ties to another kind of common mistake or something that's less appreciated is the market by market variability of these IDNs. I mean, Providence, for example, spans, as you said, I think 7 states, each have their own competitive landscape, risk appetite, or even physician alignment models. And so, from your vantage point, what should startups be paying closer attention to when it comes to market level fragmentation in these organizations?
Yeah, so that's a tough one, but that's really important. And you pretty much said you have to know your audience. And so you need to do some homework. If someone came to me tomorrow and said, I really have a great idea for risk bearing in the state of Washington, which is where I'm currently located, I would say there's really no risk in Washington. There's not an appetite. The network's not set up for that. And the payers aren't even interested. Don't talk to me. If they came in Oregon or California, it would be a completely different story. And depending on the state, it could even be down to an individual metropolitan area. So I think it helps to understand who the audience is. And when you try to sell blindly, it usually falls flat.
Sure, yeah. If you just treat Providence as one organization, it's not very helpful. Layered on top of that question, there's also external constraints to local fragmentation at the state level with things like regulations and labor dynamics, which often shape how fast change can happen in ways that aren't always obvious to tech startup teams. In your experience, how much do those external factors impact a system's ability to implement new care models or operational changes?
Oh, that is a phenomenal question. So I moved, as I mentioned, from the Midwest to the West Coast. Every state in the country has kind of a different regulatory framework and a different kind of political bent. The West Coast is the state regulatory bodies are very active in ensuring that their priorities are met, coupled with the other thing you didn't mention, which I think is vitally important, the labor kind of how labor is organized state by state and locale by locale. There are many health systems that have very low union penetration and others that have a lot of labor unions. And labor union contracts can often prevent you from using technology or at least adopting it without very specific expectations. So between those two things, between labor contracts and between state regulatory bodies, there are many, many hurdles. And that is something that I wouldn't necessarily expect a startup to really know or understand the nuances of, but they have to go in recognizing what they say could be easy, might not be, and they have to listen quite a bit to their stakeholders to understand how to tackle those.
Sure. And if you're not even aware to ask about these things, you wouldn't consider them until it comes to implementation, and then it could fall. So I think that's what's useful about this whole exercise is even just understanding up front what you need to be asking about or aware of. But certainly
Precisely.
it's so complex that it's just about asking a lot of consultative questions and getting to the right people.
So I could share real quick that I had a slide, I got to find it somewhere, that shows healthcare regulatory regulations in the US, and it shows every regulatory body that regulates an individual hospital. And if I took any hospital we have, there'd be 53 or so boxes sitting around that hospital coming in, federal, state, municipal, local, all of those, and very often the regulations don't line up, meaning one will say one thing, another will say something completely different because they're not made together. And startups, anyone else coming to do business, has to help us navigate that.
Wow, wow, that would be an interesting slide to get my hands on. That sounds like
It's a good one.
good visualization of the chaos. Yeah. Related to buyer mapping, we also cover financial signals, including asking, has there been any change to how innovation budgets are governed or funded? And is there a dedicated team focused on investment, co-development, and innovation, or is it more ad hoc? And I think it's interesting to bring it up here just because earlier this year, Providence stood up an Office of Transformation, bringing digital health, AI strategy, and tech partnerships under one umbrella. How should vendors looking to engage Providence interpret that move? What does it mean to them?
Yeah, I think Providence is actually very interesting in that over the last decade, we've probably been amongst the most innovative health systems in terms of not only trying new technology and partnering with folks, but actually developing and spinning out our own. It's been something that's been very kind of near and dear. With that said, there's a lot more financial pressure coming out of COVID and a lot more rigor on ensuring that, in the startup world, you can make a lot of bets and you hope one or two kind of win. We at this point don't really have that luxury, and we're really looking for winners to start with. So our we had a venture fund which is now spun out. We are still active participants, but it's not solely ours, and that has been very successful. And then from the Office of Transformation, that word transformation can be interpreted many different ways, and it's very broad. We have sought to bring focus to it, and the transformation we're focusing on to start with is easing the way of our caregivers. So, our doctors, our nurses, we want solutions and technology that'll make it easier to practice medicine and to take care of patients as a kind of our narrow task to start with. And so the technologies we're looking at and partnering with are doing just that, like ambient voice dictation, different ways of honing down patient providers in baskets in the electronic health record and so forth. That will probably shift over time. We'll have different priorities, but I think you probably will find a little less appetite across the country for the broad expansive, we're going to like try to do a little bit of everything and be our own kind of fund now than you'll find less of that now than you would have 5 or 8 years ago.
Sure. So if I were to maybe rephrase it to some extent, perhaps moving towards a new phase where you're looking for opportunities with better chance of driving scale that are more proven, less proof of concept, more maybe early enterprise contracts that can
Yes.
really drive an impact shorter term.
And maybe the one other thing I should add, which I think is probably maybe the most important point I'll make. I think there was a time where various vendors and folks with different solutions would come to us and say, I have a solution for a problem you might not even know you had or a problem you weren't really thinking of. And we would probably entertain it. This is here. This is my last organization. That was kind of the ecosystem. I think we're now to a point where we say, this is a problem we're trying to solve. Who out there can solve it for us? And if someone comes knocking on our door with something novel, unrelated, just don't have the bandwidth to take care of that right now.
Sure. I guess it's a signal of the maturity of the market, having been a certain amount of years into this digital transformation, initiative. Now it's more clear where you can really drive the impact and what is more experimental. So it makes sense. And so that's kind of a good lead in, looking ahead, are there, significant buckets of opportunities that you believe a Providence with its kind of both payer and provider arm and kind of spanning across the care continuum is kind of better positioned to take advantage of that could really unlock real value from the scale and local presence of such a group?
So the short answer to that is yes, with an asterisk. So I think there's clearly in the intersection with payer and provider, there even still, even with our own plan, there exists challenges with data transfer, exchange, and really understanding the member and the patient. And I believe, and I'm sure you do too, that technology will help us bridge that gap over time, very much so with our own payer. And ultimately, when there's trust and the right systems in place with external payers and providers, I think that's key because right now there's friction between. So that would be one that I think being a payvider is helpful. I think technology on the other sense, from the provider standpoint, aside from I mentioned trying to make it easier for caregivers. I think there is a huge need for deflation in healthcare, and we keep on hiring, not Providence, but in the US healthcare, more people to do more things like our rev cycle and so many other areas. And these things are ripe for disruption, and AI might just be the place that will do it. And best in class solutions that we can scale are going to be huge. The challenge I think we'll have is there's going to be a lot of people out there offering things. We need something that we know is safe, that has cyber is a huge problem for us and something that we really believe can scale. And sometimes the smallest of startups have a tough time proving they can scale to, the size that we have.
Yeah, and I remember last time we spoke, you mentioned this concept of deflationary solutions, which I love. And if I were to understand it correctly, it's about not just lowering costs, but driving more sustained cost compression without, adding the physical infrastructure or headcount or fixed assets. So kind of structurally making it less expensive, which I think is such a good way of framing it. It makes a lot of sense. Is that something you actually have started mapping out as a kind of priority? You mentioned the Office of Transformation already kind of
Yes.
has some ideas as to where to look. Yeah.
So absolutely, and I would say transformation. I mentioned what we're focused on, but if you look at us as an organization over time, I think it goes beyond even an Office of Transformation.
Yeah.
If you look at every health system in the US, the provider side of it, about 50% of its OpEx is human capital, it's labor. We are a service industry no matter what. All of the other things are kind of small pieces. And then at the front line of care, I think, and this is almost frightening, US aging population, baby boomers, Medicare, thousands every day. We don't have enough people entering the workforce in healthcare to take over those jobs, let alone doctors and nurses. There are going to be huge shortages in the US with more complex patients. If technology doesn't find a way to fix that, we're going to be in trouble to amplify the scale. And all of that not only should improve quality, but really needs to prove deflationary, or US healthcare will be 30% of the GDP. And who knows what's going to happen at that point.
Sure. With a shortage of labor and increasing costs over time, there's really no, I mean, it's not that contrarian to believe that you will need more of these digital solutions, for this system to be sustainable. And I think what's exciting for the startups we look at is that it's no longer just selling into the relatively modest IT budget, but rather looking at and augmenting or enhancing the labor line item, which, as you mentioned, is just orders
It's
of magnitude
huge.
larger. Yeah,
And I should add, and I know I shared with you once before, but I think it would be helpful for maybe the audience to hear that, I don't think I'm saying anything novel, that over the last 20 years, the addition of technology in healthcare, more or less, is probably the only industry where you add technology and you have to add more people.
yeah.
You add an electronic health record, and then people hire scribes because it's so hard to navigate and manage. It is mind numbing. And so, as we think of the future, the beauty will be technology that actually makes us work better and more efficiently, like just about every other industry there is.
Sure. Finally, technology being adopted not just for regulatory reasons, but because it's driving real ROI and value. That's
Exactly. Go figure.
new era. Yeah, exactly. And so kind of tying it together, the manual is really a collection, as I mentioned, of questions that founders can use to speed up their learning about where an IDN is in their integration journey and to better understand them. And so in that spirit, what's one thing most founders or potential vendors get wrong about how IDNs really work? And one question you wish that they would ask, but but rarely do.
That's a tough one. Um, I would go back. I would say, as far as something that they should know, I'm going to go back to a little bit what I said before. I think when you meet one, and that's the unfortunate challenge. And so I think there are a few generalizations, but there are so many specifics. And the larger the provider or the payer gets, the more complexity there is. And so you have to go in knowing that when you have a solution, that solution probably is not going to be a one size fits all for any decent sized organization. And I wouldn't go in with the hubris saying it is, because that is an immediate red flag to those of us that are on the other side of the table. And then as far as question, I think, and I'm going to go back to kind of an earlier comment, what is in this area, what is the biggest problem you're trying to solve? And then you can figure out how your technology helps that, or whatever your solution is. I think too often people come with, this is my solution and you have this problem. And
Mhm.
that doesn't really work.
Sure. That's a great way of phrasing it. The founders or vendors need to kind of toe this line between coming with a vision and with a strong statement, but also, of course, tailoring the messaging and really making sure it resonates. So it's very interesting to hear from your perspective that when they don't do so, this is an immediate red flag, and can really harm the sale and relationship building. So it makes a lot of sense. And last, on a more personal note, you've been building really a career inside these large health systems, and so to you, what makes these IDNs, despite all their complexity, still one of the best bets for driving meaningful change in U.S. healthcare?
At the end of the day, if you don't pay, if you don't control the wallet, it's hard to make change. And when you have both sides of it, the wallet is there, the change can happen. And I think the one thing that's universal that everyone in healthcare hopefully believes is we need to get better. We need to get more efficient. We need to get higher quality. Everything we need to do, I think having both sides of that makes it easier to do. So it's exciting time. I think all of the threats and pressures and challenges that are coming, Medicaid in the US and so forth, will hopefully drive more innovation to make us even better yet.
Yeah, it's a great point. It's even if you think you're just selling to a provider or a payer, you always need to consider the invisible incentives that exist between them and the other side of the wallet. And an IDN maybe perhaps makes that more explicit, where you can actually improve the pace of learning and aligning those incentives before you kind of go to the wider ecosystem. So that's great.
Yeah, you said it more eloquently than I, so thank you.
Well, thanks. That's a great place to end on, Darryl. Thanks for your time today, and looking forward to continuing the conversation in the future.
My pleasure. Thanks for having me.